So this is the on video part of the PowerPoint that I didn't get to in class. So this is the first slide that was missing from the lecture, nursing management of pelvic support problems. This is a person, would be done for a person with, it could be a cystocele, it could be a rectocele. Also, usually pelvic support problems, we're talking about the uterus prolapsing into the vagina or through the vagina out into, past the vaginal entry area. So there are things a person can do on their own, such as Kegel exercises, which your book talks about on page 1301, and it mentions it in other places too, that we can teach our patient that's having this problem to strengthen this whole area, and that strengthens the walls of the vagina and the bladder here. And also people that have a cystocele, which is where the bladder kind of falls back into the vaginal area, and a rectocele. Well, with the cystocele, they may have an area here that doesn't drain very well because of the way that if it's large cystocele, it will not drain in the normal way that they would usually expect when they get up and they empty their bladder. That area may not drain all the way, and that can promote more frequent bladder infections. So we want to make sure that we're teaching our person that has pelvic support problems about risks and signs and symptoms of bladder infections. With rectocele, the person may not be able to push stool past if it's collapsed into the vagina. There may be an area that it just gets hung up. So again, Kegel exercises will help that person. And with the uterus, collapsing in here, with aging, sometimes these ligaments, the supports that hold the uterus in place, decrease in their strength, and gravity pulls this uterus down into the vagina. Excuse me. So what they show here is a pessary device, a little support for the uterus staying up out of the vagina. And or this person might have surgery that would help with this, and usually they may have an incision in the vagina. It could be they have an abdominal incision as well with this kind of surgery. But they're going to come with a Foley catheter in place because they want this bladder to remain empty so that there's not much pressure put on this operative area. And also they're going to give the person laxatives because, just like Colace, just to keep that stool soft so they don't have to push hard or don't have a risk, of constipation. They're going to need to do Foley care because they're not going to be staying in the hospital for 4 days. Used to be we did this, and then when we pulled the catheter out, we would do bladder retraining with them. But mostly people are sent home with that catheter in place, and they follow up at the physician's office. So our post-op care of them is going to include patient education and hopefully demonstration by them that they're able to do this, as far as taking care of the catheter. During the catheter care, we show them how to clean away from the meatus, and they may need to do some care of the site, twice a day where they had the surgery. And this may just include sitz baths. So how would they get a sitz bath? How do they use a sitz bath? That's just going to be cleansing the area. And then do perineal care very carefully after having a stool. We want to teach them signs and symptoms of infection and to take their temperature every day, and when can they resume sexual activity. In fact, we may not have that information as they're in the hospital, since they're leaving only a couple days later. But bring the subject up so that they know not to have sex until the doctor gives them the okay. We were talking in the slide, the last slide of the lecture. We were talking about different problems that females have, and one of them was endometriosis. And this is just a slide showing you what endometriosis, and this is the endometrial tissue of the lining of the uterus that has migrated outside of the uterus and is responding to hormones elsewhere in the body, usually close in the area, such as by the fallopian tubes or in the pelvic area. But it can cause very painful periods and problems. So these are common areas where the endometrial tissue might land, and you see them listed there. And now we're going to move on to cancer of the female reproductive system. Cervical cancer is the first topic that we're going to look at. Cervical cancer is, the cervix is the area between the top of the vagina and the opening of the uterus. And this area is what is tested in the pap smear, the test that women get every 1 to 3 years for testing of health. There's a virus called the human papillomavirus that has been associated with causing cervical cancer. And there's also a vaccine that can prevent the development of cervical cancer, even in people exposed to that human papillomavirus through sexual activity. And it's called the Gardasil vaccine, and it is recommended that it be delivered to girls and boys between the ages of 11 to 12. And this is because hopefully at these ages, these children are not sexually active yet. So trying to get them the vaccine before they become sexually active. There's some controversy about that, as people don't always want to bring up the topic of sex to their child. And also the shot, when I was getting my master's, I was working in the San Luis Public Health Department where they have vaccines, they give vaccines. And the girls would say they're very painful vaccinations. So, but I mean, if you compare that to having cervical cancer in your 30s, certainly I think it's a better choice. But these choices are made by the children's parents. So they are a series of 3 injections at different times, staggered, like the hepatitis B vaccine is. And so other than that, for prevention of cervical cancer, we've made huge progress by doing annual screenings, or they say every 3 years for people between 21 and 65. But usually many people get the pap smear every year, a little scraping from the cervix that's looked at under a microscope. And what they look for is abnormal cells. Remember our slide on differentiation. Cells that show that they are becoming different than the normal cervical cell. So they call it dysplasia. And so if you catch the changes early enough in the early dysplastic time, you can do very non-invasive treatment for this person, such as like the freezing the area, cryotherapy to the area, or other types of things. So advanced cervical cancer can metastasize, and you see in table 5411 that there's stages of cervical cancer, just as there are stages of other types of cancer, where they talk about whether it's confined or whether it's metastasized. Endometrial cancer is cancer of the endometrial layer in the uterus. And this is a cancer that doesn't progress quickly and is frequently, and it metastasized late. So it's a slower growing cancer, even though it's adenocarcinoma usually. And it can cause abnormal bleeding. So frequently endometrial cancer is a cancer of a postmenopausal woman who doesn't have periods. So then any kind of bleeding in a woman who's postmenopausal should be looked at as potentially endometrial cancer. But because you have time, because it's slow growing and also that it metastasizes late, usually the surgery is the treatment, and the person might also have chemo and or radiation treatment, but surgery to remove the uterus and the fallopian tubes. So hysterectomy with bilateral oophorectomy. And ovarian cancer is our next topic. This is a really tough cancer because it's asymptomatic while it's in the early stages and the medium stages, and it's usually not diagnosed from symptoms until later stages, but there's very little that can be done to help the person. It's the 5th leading cause of cancer deaths in women in the United States, even though the numbers of it are not that large, but it's very deadly cancer. There are some diagnostic things that can be done. I mean, a CA-125, which is a cancer screening, can show elevated levels in a person that has ovarian cancer, but it can also have elevated levels with other types of cancers. But it is positive in 80% of women who have the epithelial version of ovarian cancer, and which is 90% of women with ovarian cancer. So it is a value in running those screening CA-125s every year. Even I feel if insurance doesn't pay for it. But only 20% of ovarian cancers are diagnosed at an early stage. So 80% are at an advanced stage. And this is very difficult because this cancer can spread all through the abdomen and in kind of a disseminated form throughout the peritoneum, and it causes a very difficult time for this person. So let's see. Risk factors are people with BRCA genetic mutations, and as we are speaking of, a lot of these mutations happen in the person's lifetime. They're not hereditary from previous, but there are BRCA changes that can develop in families, and people with familial history of BRCA changes, and also familial history of breast or colon cancer are at increased risk of endometrial cancer as well. People that have not had children, like have not given birth to children, women that have not given birth to children are at increased risk. And some of the protective things are women that had multiple children, that had their first child early in their life, that breastfeed, or that are on birth control for greater than 5 years because they feel that this is because the decreased level of circulating estrogen for that period of time when the woman was pregnant, breastfeeding on birth control pills. So if there is a pelvic mass, they can use that OVA, your book talks about OVA1, to test if the mass is benign or malignant before it's surgically removed, but that's not a preventative situation. What I've seen with people with ovarian cancer is that they get this edema or fluid-filled abdomen and lower extremities, and it's just a very painful, difficult way to proceed toward the end of their life. Your book has a couple of good tables, so genetics and clinical practice, talking about ovarian cancer, and collaborative care of what we would do for a person with surgery. Obviously, we want to remove that ovarian cancer, so they're going to have surgery to remove that. Radiation can be used to decrease the size of masses before being removed, so that might be something that works for this person, but there's really no screening test specifically for ovarian cancer, so it's pretty tough. And we'll talk in general about surgery for the uterus or abdominal cancer in further. I also wanted to mention that ovarian cancer, the person does not have vaginal bleeding as one of the signs and symptoms of it, like they do with the endometrial cancer. So ovarian cancer, that is not an early sign. Okay, vaginal cancer is pretty rare. Your book talks about like 2,600 plus people, and treatment of that is just to remove it, and the person may have radiation and or chemo, depending on the stage of it. And then vulvar cancer, the vulva out here where if there's a lesion or a growth, women can have that. It's like less than 5,000 new cases a year. So a woman wants to keep an eye on the health of those tissues and what they're looking like. Usually this will be a painful or bleeding situation, and hopefully the woman will seek help based on that. So they might use laser therapy or surgery to treat that. In general, these signs and symptoms that you would see, leukorrhea, so vaginal discharge or vaginal bleeding that's not expected, increased abdominal pain or pressure, and that would be like ovarian cancer with fluid in the abdomen, bowel or bladder dysfunction, and vulvar itching and burning would be signs that this person should seek help of a healthcare provider. And I guess I got off my track and started talking about ovarian cancer earlier, but ovarian cysts occur in many people, but that's a benign tumor and it may or may not be removed. If an ovarian cyst becomes large, like you see in this picture, or if it ruptures, that would be an indication for surgery. Or if it's causing the person severe pain, such as it's pressing on other organs or causing problems such as dysmenorrhea or constipation or other problems, then a person could opt to have the ovarian cyst removed. But it is a benign, not going to develop into cancer. I think I pretty much talked about the rest of the information on this slide about ovarian cancer. So usually it's diagnosed in people that are over 40, and as I spoke about this, I don't think I mentioned the high-fat diet being one of the risks of ovarian cancer. And that's an ovarian tumor. So signs and symptoms, if a person is pretty vague, but if they have the feeling of fullness or fluid accumulation, if they are having abdominal pain, it could be lots of things, but one of the things it could be is ovarian cancer. So they should get a pelvic ultrasound and anyway, seek out medical help. So fluid accumulation from ovarian cancer, it does cause pain as it presses on the different organs, and then these other symptoms. Late signs that spreading to the peritoneum and the dissemination through the peritoneum and increased fluid causes that increased abdominal girth, and then pain, and then menstrual irregularities if the person is still having periods, and ascites. So no screening test exists for, we're talking about ovarian cancer. Pelvic examination, this is one of the big reasons why the physician, for you women that out there that have your Pap tests and your pelvic exams, this is one of the things that they're doing when they're doing the pelvic examination, is feeling for the ovaries and looking for any masses. So the woman might have a CT or an MRI. The BRCA gene and the CA125 can help to identify those people that are at risk. And if you have a CA125 test before it starts going up, that might be an indication. So you have like a normal, or you have a pre-diagnosis CA125, and then you can kind of track how the cancer is going if you identify a cancer later on. So they're going to do an abdominal and transvaginal ultrasound to identify this. They may do a tumor biopsy, and they may just do a laparotomy. And with the laparotomy, they're going to stage what level this ovarian tumor is at, and if it's metastasized, if it's gone to the lymph nodes, and if it's metastasized elsewhere in the abdomen. Sometimes they can get a good idea about how advanced this is when they open it up, like you saw in that picture, and take a look at the site, the area. Collaborative treatment, they're going to have a hysterectomy and a salpingo-oophorectomy, and they may have chemotherapy, they may have radiation, and if there's metastases, locate where those are. So people that have, women that have the uterus removed, is called a hysterectomy. The approach can be either abdominal, it can be a transverse or a vertical incision, or they can remove the uterus through the vagina, so it'd be a vaginal approach. And I have a diagram on the next page, or pictures. So this person's going to come back to the floor and spend a day or two usually in the hospital. And one of the things we're going to watch for is bleeding. If a person had a vaginal approach, they're going to have vaginal packing. The packing will be removed by the physician, not to be removed by the nurse. However, and usually the next morning after surgery, the physician will come by and remove that. And it usually relieves a lot of discomfort, because the packing can cause some pain in the area, because it bumps up against a surgery site and causes pressure on that. So let's see, it's very similar to abdominal surgery, especially if it's an abdominal approach. The person may have a Foley catheter to decrease any stasis of urine causing infection in the area, just to decrease the pressure of a full bladder on the incisional area. We want to keep this person taking nice deep breaths, and if they have an abdominal incision, of course, it's going to be a little more resistant to that. So we might provide them a splint to help hold against the area. If the deep breathing makes them cough. They might use PCA or other IV pain medication to try to decrease their pain. And certainly, especially if it's removal of a cyst or a large mass, that can cause change in the location of things in that pelvic area. So, and the person can be prone to having an ileus just from surgery. So we want to get them to ambulate. So we want to treat them for pain and get them ambulating to try to decrease any kind of abdominal gastrointestinal problems. For DVT prevention, we're either going to have the STDs on, giving them heparin and or early ambulation. And diet, sometimes people will have nausea, from the pain medication and or from the anesthesia they had. So advance from ice chips, clear liquid, to regular diet is tolerated per the physician order. Bowel pattern, we're going to have them on the stool softeners trying to prevent straining and constipation. Psychosocial, removing the uterus and either the fallopian tubes or the ovaries or all of it causes women to really grieve for not being a woman anymore. So trying to support them that way. And we want to teach them also to avoid any heavy lifting for up to 2 months or until the physician says, and I mean like anything more than 5 pounds. And then no sex usually for 4 to 6 weeks or until cleared by the physician to have intercourse. So this is the vaginal approach. They will go through the vagina and pull the uterus out through there. For the abdominal approach, it would either be that vertical incision or the transverse, which is also called the bikini cut. So we want to recognize that nurses play a role in our patients getting preventative care, and we want to decrease any disparity in preventive care and or treatment across socioeconomical or ethnic differences. So we want to promote people getting the tests that will help prevent or recognize early cancer. We want them to do the self-exams and promote healthy lifestyle as we spoke of in class. Thank you.